I wanted to thank everyone for being part of this panel discussion on organizational perspectives on implementing and sustaining EBPs in community mental health. I'm Georgiana Sedlar, and I'll be moderating the panel discussion today. I'm on faculty at the University of Washington in the Division of Public Behavioral Health and Justice Policy, which is within the Department of Psychiatry and Behavioral Sciences. And so thrilled to be doing this panel discussion. We have a lot of participants registered, and so what that tells me is that I think this topic is of great interest and very timely. And I just wanted to say that this presentation is the first of many that we'll be offering throughout the year. That's part of a workforce lecture series offered by the Evidence-Based Practice Institute here in our division. So just stay tuned for other interesting lectures that are coming up over the next year. I'm really pleased, as I said, to be moderating this panel discussion today. We decided to focus on this topic after getting a lot of feedback from and having conversations around the state with providers, supervisors, administrators, that this topic of how to implement and really sustain EBPs in community mental health was of great interest. And we thought, what better way to really understand and talk about this issue than to get perspectives from the people who are doing the hard work day in, day out, and dealing with implementation and sustainment of EBPs in the real world and all the messy challenges that go along with that. So the plan for today is first to I'd like to take a quick gauge of who's participating in the webinar today, and then would like to introduce our wonderful panelists, and then get right into talking and hearing from our panelists responses to questions related to implementation and sustainment. And then finally, we'd love to hear from you. You'll get a chance to ask questions through our GoToMeeting platform as you're hearing the panelists talk, that you can ask questions, and I will be asking those as we get farther along in the broadcast. So, and then we'll wrap up by 1:30. So, just really quickly, we'd like to know kind of who you are in terms of the work you do, and you should be. So there should be a poll that should be popping up. Oh, people are already on it. That's great. So going back to, so if you're kind of university-based, if you're a professor, graduate student, researcher, hopefully you can see all those. It looks like people are doing this quite readily, which is great. So we'll just give another minute to see. So it looks like we've got about a fourth are university-based. So it's changing. Yeah, almost a quarter are university-based. Almost a quarter of you are in some kind of administrative or senior leader position in community mental health. About a third of you are supervisors and/or clinicians in community mental health. And then we have about 10% who are in state government policy positions, and then 10% other. So that's great. We have a really nice representation of folks. So, and again, thank you so much for being here. So now I'd like to introduce our panelists. I've had the pleasure of knowing these folks for some time in my work on CBT+, which is a statewide training initiative that trains mental health providers in 4 evidence-based practices for youth around Washington state. They are all experienced clinicians, supervisors, and leaders within their organizations, and steadfastly committed to using evidence-based practices and really working to make sure that EBPs have taken hold at their organizations, and always sort of focus on how they can improve practice at their organizations. When they've had a lot of success within their organizations in implementing sustaining EBPs, which is why we call them EBP champions. And so our first panelist is Rachel Barrett. She's the Chief of Clinical Services at Ryther, a behavioral health organization in North Seattle. She is a certified school social worker and licensed clinician with experience working in schools, clinics, and residential settings. She enjoys treating externalizing behavioral problems, particularly those masking internalizing problems like anxiety, depression, trauma. And then next, we have Dan Fox. He's a licensed clinical social worker and clinical manager at Lutheran Community Services Northwest in Spokane, and he's been at Lutheran for over 13 years. Russ Funk has been working at Cascade Mental Health in Centralia, Washington for 12 years, where he supervises the child and adolescent program for 8 years. He has been in community mental health for almost 20 years and has been active with TFCBT for over the last 5 years. And then our final panelist is Ron Gengler. He's the COO of Comprehensive Healthcare, which was formerly known as Central Washington Comprehensive Mental Health. He's been with Comprehensive for just over 24 years and in the mental health field for 27. He started as a case manager therapist. He has worked primarily with children and families for most of his career, and professionally he considers himself first and foremost a trauma therapist. So thank you, panelists, for taking time from your busy schedules to participate in this panel discussion and share your knowledge with us. All right, so we'll move along to the questions. So just to let everybody know, the plan is I'll ask one question to our panelists who will each take turns offering their perspectives. And as you're listening, I really encourage you, the audience, to think of questions that you might want to ask them, and we'll have a chance to address those toward the end. And you can write those in the questions header in your go-to webinar. All right, so the first question is, what are the necessary ingredients to successful EBP implementation at community mental health organizations? So Rachel, how about if you start us off?
Sure. Can you hear me?
I can hear you great.
Okay, great. Yeah, I think that what's been really helpful in my agency is having a leadership team who really understands and supports the value of EBPs, and not just because they're now mandated for us to be reporting out on, but also that get sort of the philosophical and treatment value. And then, of course, having the financial support for EBP implementation, because in community mental health, we don't often have large training budgets for this sort of thing, and when you have turnover, you have to train a whole new crop of therapists. And I think the other thing that stood out to me was making sure that you had the infrastructure in place for adequate supervision of our therapists. So it's not enough to just do the training up front. You have to have the infrastructure for the consultation and the regular supervision.
Great. Dan, how about you? What are your thoughts on this question?
Yeah, I would echo what Rachel says, but what I'll add is that what we've done is try to saturate our agency with language and EBP information that sort of is expected. So evidence-based practice language is in all of our paperwork, evidence-based practices in our orientation training. It's something where what we do is we take whatever evidence-based practices that we have and make sure that as supervisors and directors that we are using that language when we train, when we do supervision, when we do and just basically anything in there. And so the other thing too is I think it's understanding that there is a little bit of diffusion of innovation kind of happening, where you've got certain people that will be early adopters and jump right in and want to be part of the evidence-based practice whatever it is, and then you've kind of got this early majority and late majority, and then of course then there's laggards, and we kind of understand that, and we know that those people at the second half of that adoption bell curve are going to need some extra talking to, extra nurturing, extra support. So I think that's another thing that kind of really helps us when trying to get EBPs implemented.
Great. Thank you. Russ?
Yeah, you know, there's a couple things, and I feel like I'm at the adult table at Thanksgiving, sitting on a panel with these people. So I just wanted to throw that out. You know, I think, Dan, you're keen on something that, like, you can have all these policies and procedures, and you can have examples of how to write good clinical record reflection of evidence-based practices, but you're talking about a culture. You're talking about, there has to be somebody that has a level of passion that can sit, and particularly when we talk about CBT with children, which is predominantly what this panel is pretty seeped in. I know there are other EBPs that other people have, but in terms of that, the ability to be flexible within that evidence-based practice and take some of those people who are maybe like, I want to do narrative therapy, or I want to do interpersonal therapy, and how that passion and the culture that you can develop can kind of bring them in under your tent. And it can be pretty inclusive when you start talking about thoughts, feelings, and behaviors with children and families. That can cover a lot. So the things that I got with is, like, you know, you can have supportive administration, but I think the culture and just kind of the ability to adapt people's strengths to an evidence-based practice approach, I think is crucial when we talk about necessary ingredients.
Great. And Ron, what are your takes?
Yeah, so I'm going to be at the end of some experts, so you might hear a few things repeated. The big one for us was the administrative and the board of directors acceptance of evidence-based practices, and having to report back to them on a routine basis has been critical to sustain our EBPs and be able to continue to grow and add additional ones as we've moved on for the last probably, I don't know, 15 years or so. We had DBT to start with, but then have expanded pretty significantly since then. I like what Russ and Dan were talking about and Rachel about that champion. You have to have somebody who is excited and passionate about that at the supervisory level and also at the direct staff level. And we'll talk more about that with some of the other questions. The other thing that we've done that helps the implementation process is that the interview process, when we are interviewing potential employees or candidates, is we have some pretty powerful EBP questions, because I need to know you're coming on board to a shop that really is EBP based, and I need to know your thoughts and feelings about that. But when it comes to implementation, to me it starts with the CEO. You can have some passionate people, but if you have a CEO who's kind of quasi interested in it and doesn't show a lot of passion and interest in seeing how things are going, then I think it can die off pretty easily. So that's a big one for us.
Great. Well, thank you for that. Those are all, I'm taking notes fast and furious. Those are all really good things, and maybe we can, as we go along in the panel discussion, we'll come back to maybe some of those and delve into them a little further. So, so what specific practices have you used to support and foster sustainment of EBPs at your organizations? And Rachel, yes.
Okay. Yeah, first of all, I'm taking notes on what other folks are saying. These are great ideas. What the previous person was saying, I think that we try to set the tone right from the beginning. So we did add in an EBP interview question that everybody gets. So we asked all applicants for our outpatient department, what are your views of evidence-based practice, both positive and negative? Because it ends up being a really good gauge for people's sort of openness and willingness to do EBPs, and it can be a good conversation starter. And then we use that to highlight that we try to pick EBPs at Ryther that are flexible and that allow for different kinds of therapists with different kinds of backgrounds to still sort of carry the same roadmap, but how they get there is up to them. So, you know, we have drama therapists and experiential and all of that, but we still have to follow the same map. So that's been really helpful to sort of screen up front and set the tone. And then we have sort of a basic EBP orientation that we do within folks' sort of first 90 days of hire, where their supervisor is responsible for going over the basics of each EBP. And our main ones that we have at Ryther are DBT, CBT Plus, and PCIT. And then we're considering some other ones to add. But so that sort of interview and orientation process has been really helpful. And then to foster the sustainment of the EBPs, we try to build in monthly consultations that are EBP specific. So we have a weekly DBT consult. I come in and do a monthly CBT Plus, and then we have a monthly PCIT. And we feel that in order to support high fidelity community-based EBPs, we need to have a balance against the caseload expectations. So we do cap our caseload size and try to have reasonable productivity expectations, because if we want people to do good work, we want them to have adequate training and support to do the EBPs. You know, you can't have a caseload of 70 and, you know, 70% productivity and do high fidelity treatment when you're, especially when you're first getting started.
Great. Yeah. Wonderful. Okay, Dan?
Okay, yeah. So I have to apologize for a baseball analogy. I'm not really a baseball fan, but a lot of it we have to deal with a lot of turnover at our site. It's not continuous, but it is a routine that we have a new staff member come on board because somebody wants to make a lot more money in the private sector, or we have a new graduate intern coming in. And so for us, a lot of it is about making sure that the people that are the supervisors are like a good set of coaches. We have somebody to do the training on the EBPs. We have somebody to kind of help them manage the challenges with manualized care and so forth. And so our supervisors here are pretty heavily trained and really good at processing the EBP models with clinicians. And they have high expectations regarding fidelity with these models. We do training cases with our staff on a continual basis, meaning that here's a case that helps teach them about that evidence-based model, and then we come back to it each week. We try to connect the clinicians with champions so that some of the good juju that an old clinician has that really has good connection will rub off on our newer clinicians. We try to role play in supervision some of the tougher elements that they're going to face with their clients. And you know, regarding turnover, we kind of have a plan for turnover. We know that turnover is going to happen, so we're not surprised by it, so that we really have a really good, you know, where we honor the exiting clinicians and we receive the new ones with the same verve, and we're just sort of ready for the next person, whoever that might be, to train them up so that they're good at what they do.
Great. Russ, how about you? What practices have you used at your organization to support and promote?
Well, I think the key is, and again, what we're going to find is you better mix up the list so Ron just doesn't have to say ditto.
I'm realizing that. Yeah, Ron's going first on the next question. That's for sure, Ron.
No, wait. I'm going first because I prepared, but he could go right after me on that. So the thing is, I just supervise one community mental health center team. We have about 10 clinicians. I've been fortunate that I haven't lost a clinician to private practice in about 4 years. And how I've sustained, and people have left for, usually now for promotions as our agency's kind of expanded. But what I've hired for the last 5 years, I've hired interns, people who started as an internship. And so I start that question, the first question I'll ask an intern is, can you talk to children about penises and vaginas? And that's in the first 20 minutes that they've met me. And so they're realizing that this is going to be a little different than what their graduate school experience was. And that leads to a really interesting conversation about trauma-focused work with kids and about how that really deviates from a lot of different practices when you talk about CBT for depression or anxiety, even though there's a great deal of overlap. So one of my specific practices is you grab those people early and you start shaping their expectation of what their experience looks like, and they stay malleable for a long time. And then you know, I don't assign them a specific champion, but the clinical team has taken on the responsibility of kind of this, it takes a village to raise a clinician kind of a attitude that everybody has a practice of saying, I can't help you right now, but I'll set up time to help you when they come up with questions. And so we kind of so everybody is seeped in this a similar culture about CBT. And again, I have people that do yoga. I have people that do art therapy. I have people that do a variety of things that go under the umbrella of CBT. But so we start them early. I think that's be my best case for a specific practice.
Great. Okay, and Ron, you're coming in on the end of this question, but I promise I'm going to shift it up here after this one. So, what specific practices do you use, Ron, at Comprehensive?
So Comprehensive, just to give everyone we have 10 major offices that we use, and so we've done what Dan, Rachel, and Russ have done. And then I said, because of my new position, I said, we got to do something different to manage this. I can't be the one running around and being the cheerleader at the 10 shops. So we created about a year and a half ago an EBP oversight committee. And so the committee meets on a monthly basis, and it has at least 2 members of our leadership team that meets with the CEO weekly. We have some clinical directors who love statistics that are in that group, and then we've created an EBP internal champion or internal consultant for each EBP. Comprehensive has about 21 different EBPs ranging from little kid stuff through senior adults for community stabilization kind of EBPs as well. So we have 21 consultants that we've found that they're just amazing clinicians in the EBP. So they become our experts. And so that group meets weekly. The group meets monthly. The internal consultants are required to have contact with all of the trained people who have been trained in that EBP. So for TF, our TF internal consultant is working with about 40 clinicians, and what she'll do is she will pull 2 cases of theirs annually and review them for fidelity to the EBP that we were trained on through Harborview and the UW. So that's something that, and then the consultant then submits a report to the supervisor of that clinician, and all 3 of them review the report and how we're doing and how we continue to sustain the EBP. So that's a big thing that we've made the change in the commitment. Our CEO then also approved that each of those consultants, they're not supervisors, so they're line staff. We've adjusted their productivity requirements a bit, and we've given them an add-on, a monthly add-on, because they've earned something that I want to reward them for, and the CEO was more than willing to do this add-on. It's not a huge add-on, folks. So, but when you're you're getting kudos because you're just an amazing therapist, and you're also getting a little bit of pocket money to be recognized of what you do. So those are the two big things that we do. The EBP Oversight Committee has to submit an annual report to the Board of Directors on how we're doing. The EBP Oversight Committee also does some investigation of potential EBPs that we don't have a niche for, excuse me, we're missing something for some clients. So they'll do some investigation. I'm hoping that we've covered everything so we don't have to keep adding EBPs, because if you have a small site, for example, we have a small site in a town called Sunnyside in Yakima, and if you've got 8 therapists there, they're trained in 7 or 8 different EBPs, and there's no way the supervisor can be an expert on all of those, so that's why we chose to go with the internal consultants. That's really helped us, and we just have been really successful with that.
That's great. That's really impressive and incredible coordination on your comprehensive part, but that's great. Okay, so Ron, clear your throat, get a glass of water because you're up for this one. I'm going to let you go first on this question, Ron. So I'll work backwards, I think. What barriers have you encountered in implementing and sustaining EBPs at your organizations? And then what strategies have you used, or what do you recommend in terms of strategies for overcoming them? So Ron, if you're ready to take it away again, we'd love to hear from you first.
So I think Dan mentioned, I don't know how Russ has been lucky not to have staff turnover, but that's been the biggest one for us is staff turnover. And being able to talk with those potential employees, are you interested in doing this? But we've made the decision that this is what Comprehensive does. If you want to work at Comprehensive, you're going to learn an EBP. And a lot of new folks are really excited about that. So that's one of the barriers we have to work on. The other one is we don't have it as much as we used to, but training clinicians who had been in the field for a really long time who hadn't had experience with EBPs, that's been a barrier for us, trying to help them make the shift. Some of them have made the shift, and some of them have self-selected that they don't want to do this. And I'm happy that they make that decision because it works for Comprehensive, and I know it works for them. But I can't negotiate on whether you're going to do an EBP here at Comprehensive or not. You can have some flexibility like Russ and Dan and Rachel have talked about when it comes to a behavioral activation strategy and in using yoga, but you don't get to wander away and do therapy as usual because we don't have any data. I know Lucy's on the call, but Lucy Berliner has constantly been talking with us throughout the years about, well, what are you going to do instead of the EBP? So that's the mantra that we have throughout Comprehensive, and it took a few years to get there, folks, but it's taken, so those are the things that we've done. Strategies, pretty much, this is what Comprehensive does, and eventually it'll come down to Ron said so. And I'm perfectly okay with that because I grew up with EBPs for the last, 10 years now. Even though I've been in the field for 27, the last 10 years have made some huge changes, and I don't have a problem as an administrator saying this is what we do. So that's one of the ways we've overcome the barriers. I got a couple other, but I know that Russ and Dan and Rachel are going to cover them, so I'm going to stop.
Okay. Well, if not, we can circle back to you. So great. So let's see. We'll go with Russ. What barriers do you encounter?
Well, I think what I hear from Ron is just how exceptional Comprehensive is situated for when we start talking about how our contracts might reflect some additional funding streams besides productivity. Because I think you do have to start. A barrier would be if your leadership in your agency doesn't see value in this, or they just see it as just the flavor of the week. I think they're going to be left behind, and I'm fortunate here that our CEO actually went through. I believe he went through the CBT Plus training about 3 or 4 years ago. So you have to start with the supportive administration. But in terms of what are the barriers, let's say you do have a very supportive administration. What I have found is that there's this other level of what I call organizational noise. That's not because of the administration. It's just because of community mental health. Shifting expectations, just shifting, moving into a new building, moving out from a building, just all this constant barrage of issues that interfere, that potentially could interfere with client care, and staying focused on EBPs is, I just have seen that really kind of increase. Shifting requirements in the 47 WAC requirements for a good clinical chart. And we're not even talking about fidelity yet, because I think that fidelity is something that is going to really surface over the next 18 years, because if they start to pay agencies for providing evidence-based practices, everybody's going to provide evidence-based practices, because that's what they'll say. It'll say, yeah, that's what we do. And like the question, and again, I'm just going to focus on what I know fairly well, trauma focus. There's a 12-hour or 10-hour webinar on trauma focus. Like that wouldn't be acceptable for me for a clinician doing evidence-based practices. So there's these barriers coming up for the fidelity. It's like, how do we show in our clinical record, in our electronic health record, how do we set up our electronic health records in ways to collect data efficiently so it's not time consuming. So on fidelity is like, it's not just do they know it, but how do they show it that they know it. And I think that will be a barrier coming forward. And again, I think I'll limit my list and let others chat, but that's kind of what I wanted to add.
Okay, great. Thank you. Dan.
Yeah, I think one of the challenges that we have continually is this idea of adaptation to the model versus drift away from the model. And knowing that sometimes that becomes a barrier because, hey, I don't want to be serving a TV dinner in a box that has the same, peas in the right-hand corner every time. And so we talk about that pretty openly here. We talk about the fact that there's a difference between adaptation and drift. Adaptation is, hey, creativity within the fidelity of the model. And drift is when you hear a clinician say, well, the client didn't want to do their trauma work, and so we just haven't really been working on that. We've been working on like feelings identification. So being able to identify that and help bring them back to the fidelity of the model, I think is a key piece of business. And one of the ways that we do that is to make sure that they have really good structure, that they're goal-centered, that they continue to use EBP language, that as a supervisor I am taking a peek at their progress notes to see if they're beginning to kind of drift away or are they having good adaptation. That I encourage my folks to use an evidence-based practice component checklist that goes through those components to kind of help them stay on task, but still have a little bit of wiggle room to use their creativity. I think the other thing that works really, really well is to nurture clinicians who are doing EBPs well, and to do that in a public way. So you're praising good EBP efforts. You're keeping track of people that are leaders in a specific model, and then trying to get them additional training and trying to put them together with other people that you help them stay in touch with why they do this work, and that doing good evidence-based practice is in line with why they got into the field to begin with. And also, of course, promoting self-care and making sure that you're reviewing successful cases, just not individually, but with the whole group. We have fundraisers that we do where occasionally, if a client is willing, we will have an evidence-based practice client talk in front of a group. And we've actually been getting away from that now because it puts a lot of pressure on the client, and we do these little films of a client talking about what it was like to do treatment there. And what it does, everybody gets to see that. All of our clinicians, all of our supervisors, all the directors get to see the successful cases. What I find is when a client has a really successful case using an evidence-based practice, that they really have an emotional connection to the model. And then it becomes less challenging to try to coerce them into doing the evidence-based practice. And now they're kind of in love with it. It's like, wow, I just helped this kid talk about his trauma, and he feels proud of himself that he can talk to his mom now. To be able to bring those out and connect those to the fact that it was an evidence-based practice that got the family there is I think really critical.
Great. These are all wonderful. And Rachel,
yeah,
how about you?
Yeah, I mean, people touched on a lot of the high points, but yeah, if other presenters have an EBP fidelity checklist they're using in supervision, I'd love to see it. You can send it to me. 'Cause that's one of the things that I've been trying to get started for us. Yeah, I mean, I think a lot of the barriers are things like turnover. We've had a period of pretty rapid expansion here at Ryther in our outpatient department. I know with the Affordable Care Act, a lot of places, had expansion. When I started as the director of outpatient about 3.5 years ago, we had maybe like 8 to 10 therapists, and we saw around 250 clients a month. And now they're a team of like 30 to 35 therapists, seeing about 650 clients a month.
Wow.
So, yeah, that was a lot in 3 years to tackle. So when we first started, you could say any client name, and I could say who their therapist was, and I sort of was able to go in and do that monitoring of progress notes and help shape treatment. And then it got to a point where I couldn't do that anymore. So we have a bunch of lead therapists who do part sort of half-time, their own caseload, half-time the supervision, and trying to sort of train them up like those coaches to be able to do treatment fidelity. The other thing is just a barrier is lack of time. So even when we can build in, regular weekly supervision, there's such onerous paperwork demands from our BHO. I hope no one from my BHO is going to get me in trouble, but from BHO, and then even the CBHR a little bit, that we have to use some of our supervision time just to teach how to do charting the way these different folks want us to chart. And Shannon Dorsey did that survey for the STEP study asking community mental health folks what they want in supervision. And I've been repeating that every year with our therapists here to sort of get like, who wants more administrative support? Who wants more of this? Who wants more crisis management? And the therapists consistently say they want more EBP support. But how do you do that when they also have, a kid in a terrible crisis? It's a lot to balance. And we do tend to get really high-risk kids here because we have an inpatient program and a CBT program. So you have to give part of your supervision time to addressing risk formulation, but you don't want to leave the EBP out either. So yeah, I'd love to see these EBP fidelity checklists and give them a try and see if that helps.
I can send those along to you.
Thank you.
Great. Okay, well, we've kind of been talking about this this next question. So if you want to expand upon maybe your previous comments about the role of supervisors, the role that they play in successful EBP implementation and sustainment. Why don't I have Russ? I'm mixing it up on who's going. So Russ, what are your thoughts on I know we've been talking about that, and it's certainly a main theme that's coming up is how important supervisors are to successful implementation and sustainment. But if you want to expand on that, or talk about maybe specific things that
I'll expand on it.
Cascade.
I'll expand on it rather quickly because I kind of caught what time it is. I think simply put, if your supervisors aren't doing this, it's not going to happen. You might, if you say it's going to happen. So the supervisor is the linchpin to successful implementation of evidence-based practice, in my opinion. You could have, without the supervisor, you could have individuals who are doing it quite well, but in terms of a culture, it has to start with the supervisor. And being that I'm the supervisor, I can speak about my experience. When I start straying off what I call the beam, if I start getting away from it, if I'm not focusing on it as much as I need to, I kind of create a parallel process with my supervisees the same way as they do with their clients. If I'm less disciplined, if I let the client set the agenda, then we're kind of having a Rogerian approach to supervision, shall I say. And I think that's much less effective than whether if I provide the structure of the session about bring a case in and let's review the components of trauma work that you're doing with this client. Because our expectation is that's what they're doing with their clients. If the clinician is unfocused or has all those issues and walks into the session and goes, I'm just going to ask the client how they're doing. You know, they could fill 50 minutes to an hour of time with that discussion, but that's not an evidence-based practice. So the parallel process between the supervisor and the clinician is very reflective of the clinician with their client. And it's about trying to stay focused. And how I do that is I force myself to go to trainings like we did a couple weeks ago. I force myself to sit on evidence-based practice phone calls like this. And because then it just stays, it's more relevant to me. So that's how you keep a supervisor on track, is you help keep them structured.
Great. Ron, how about you? What role? I know you've talked a lot about what comprehensive does with with your internal consultants and supervisors, but anything you want to add about the role of supervisors in successful implementation and sustainment?
They have to be a part of the EBP community externally. So for CBT Plus that we provide, all of our supervisors are a part of the CBT Supervisor Collaborative group that meets monthly. They attend the supervision training for other EBPs that we use. Our supervisors are in contact with the developers of the program or the lead trainers in the state. For example, PCIT, we work with Naomi Perry closely. So that's another thing, is having the supervisors be connected really well within that EBP's community, not just within Washington State, but nationally. And that's really helped build the excitement for those supervisors. The other thing is we just want them to encourage their staff, and we talk about when is the next booster training coming for whatever evidence-based practice that the clinicians need. Are you looking for do you recognize your staff members, your therapists, and bring their names forward in leadership meetings and team leader meetings and recognize those successes? I think that also gives our supervisors that their input is important, and it goes far beyond their individual teams. It goes all the way up through our board of directors. They know about the successes that, not all of them, let's be realistic, but they know about the successes that our therapists are doing with the evidence-based practice. Then our supervisors are excited. They stay champions. They're the big cheerleaders, and they're the ones that if I make a non-EBP-like statement, they're not afraid to challenge me. And I love that about how we've been able to establish that here at Comprehensive. So.
Great. And Rachel, let's go next to you about the role of supervisors.
Sure, yeah, and I'll be brief because I know I want to hear how other folks are funding this. So I want to get to that question.
Okay.
Maybe there's a secret pot of money.
Yeah.
Yeah, definitely supervisors are so important. All the reasons folks said, set the tone. They can monitor, therapist resistance to EBPs and sort of challenge and support them when appropriate. I also think I like to have myself and all of the supervisors carry a small caseload so we can model for the staff that it's okay to ask questions. It's okay to be uncomfortable learning a new thing. It's, like I'm a pretty good CBT therapist, but I'm like one of the worst CBT therapists. It just does not come naturally to me, and so they see me asking questions and being uncertain, but still embracing trying something new. Yeah, I mean, I think all the reasons other folks said too.
Great.
Now let's talk about how to pay for it.
Yes. Okay. Dan, is there anything, I don't want to leave Dan out, any additional words of wisdom before we move on to the big money question?
Well, for me, I understand, because I understand myself, I know that sometimes I drift as a supervisor. Sometimes I am not as good a supervisor as other days. And so I actually use a supervision checklist to kind of help, in those days where I might be feeling queasy in my tummy or whatever, that I have something to kind of help keep me on point with a clinician. And so I'm asking about which EBP they're using. I'm asking about their training case. I'm not following the clinician's crisis of the week or being too flexible. I have a very clear expectation of fidelity, and I invite creativity within the bounds of the model. And so, and I also understand that sometimes resistance from my clinicians is based on countertransference. Maybe they're getting ready to hear a story from a kid and it terrifies them. And so something like that can mean the difference between having fidelity and doing the exposure work or running from that. And so being intuitive to that, those moments when somebody might be not just drifting away from the model, but just scared of what's going to happen next. The other thing, this has really been super helpful in our shop, is we have a living library of clinical information that actually is just ginormous now, that is really keys upon all of our evidence-based practices, and even components within an evidence-based practice that people wanted more information on. We have a library inside of our computer where somebody can click and then find all kinds of rich information that we've been collecting over the last 10 years. We laminate handouts that might be super helpful, like cheat sheets for EBPs. We talk about how the EBP can be put into what we call the golden thread throughout the intake service plan and the progress note. And so, yeah, I think understanding that it's a process and not a light switch helps me to understand that sometimes I just need to walk beside this person and kind of get them past some of the tough places so that they'll maintain this connection or this passion for the work and for the model that helps them do the work.
Great. Those are all wonderful. Thank you. Okay, so the big money question. Tell us, and Rachel, I know you're eager to hear from others, but why don't we start with you? See if you have any. How are you able to fund EBPs at Ryther?
Well, we were fortunate. We had one family who wanted to help enhance EBP use and gave a small donation that we were able to earmark for EBPs. So we used that to pay for the super expensive DBT training for our director of outpatient. And she had to like sign her name in blood that she'd never leave the agency, and she can be our consultant there. And then we love the new PCIT trainer certification that Harborview is offering. So now we can get more folks trained annually than we could when it was just paying per person, because that's an expensive one.
Mm-hmm.
But we don't, I mean, we don't have like a separate budget line item for this kind of stuff. And because we believe we have to keep caseloads small, we have really thin margins for our outpatient department. So, you know, if we stacked, you know, 50, 60 clients for, and we're an RBHO, it's a case rate. You get paid whether or not you see them. You know, if we stacked with a huge caseload, we might have more money, but we don't. So we try to get our bang for our buck by getting someone trained that can then do refreshers in-house. And we're approaching some foundations because we're looking at a trauma-informed care model for our inpatient residential program, but we have to have outside funding. It's going to run us like $60,000, and we don't have that, you know, in-house. So I think we try to be creative, but we eat the cost of this a lot. You know, even just that DBHR requiring reporting out EBP usage, we had to pay, I think it was like $5,000 to our electronic health record company to just build in that checkbox. And there was no compensation from our BHO or DBHR to do so. It was just expected that we do it. So, you know, I think if there were funding streams available from the people and places who are requiring EBP usage, I would certainly go after them and snatch up whatever funds I could, because it's something that we view as important, but that it eats into our margin, whatever margin we have.
Yeah, I think that's a familiar struggle, a common struggle, Rachel. Dan, how about you? How do you fund EBPs at Lutheran?
That's a good question. I think somewhat the similar ways. We have a line item for training every year. There is monies set aside for specific EBP trainings. We know that we'll at least have interns and so forth coming through. So pretty much once a year, we'll send people to the state CBT Plus training. So we know that that's going to happen. We try to send folks to other EBP trainings, like recently the Common Elements Treatment Approach, or CETA, which is sort of CBT for adults. We funded that. I think the other thing that we have done that might be similar but different than other folks is we've volunteered for a lot of university research projects. And they tend to kind of train you up so that you're good at a model, and so we try to be at the front of the line to volunteer for those. We look for professors willing to teach certain EBP practices for free. That can be really challenging because sometimes they have their own way of doing things, so sometimes that can get us into trouble, but it's it's free. We have created some in-house training based on the outhouse training, or the outside training, actually. So that was a joke. And so and we've also been connected to the Washington State EBP initiative, which has some training for supervisors and so forth by checking in on phone calls that happen and some of the other training that happens either locally and so forth. And that's kind of ricocheted into other places and other trainings that I've had to do outside of the state, and of course it forces me to learn a lot more about the model when I have to teach. So that's kind of how we pay for it. We sort of pay for it by not paying for it.
Okay. And I don't know if, thank you, Dan, and I just want to kind of take a little time check here. This has been such a great discussion, and we're at about about 5 minutes left in the webinar. So is Russ, are you still with us?
Yeah, I'm still with you. I really don't have anything to add. From about funding, I think they covered that nicely.
Okay. Great. I didn't know if you had to go, but certainly would love to hear from you. And then Ron, how about you funding EBPs at your large comprehensive healthcare?
Well, one of the things is we have a training dollars, a budget for training dollars. No training is approved that's not an EBP unless I approve it. So if somebody wants to go to a training that's not EBP based, they've got to convince me why we're going to use that training that they're requesting instead of the EBP that we already have for the conditions that that team works with. So that's one way is we're really mindful of the dollars that we spend on training. The other one is, again, we're back to the board, and we're making comments to the board about the successes of EBPs, and when a board of directors member comes and asks you about a friend or a family member, you can quickly give information on the EBP that that friend or family member should be using, and they get success, and the board is willing to continue to support you in your EBP advancement. So that's the other way that's been really helpful for us. And your CEO gets it and says, we're going to spend the money, I'm going to spend the money here instead of other places. So that's the other way.
Okay, great. Well, I had one more question, and I've been looking to see if the audience has any questions that they want to ask. One, I know there was one question really quick before we get to the sort of final, any final sage words of advice that everybody wants a copy of that checklist, not just you, Rachel. So I don't know how you guys feel about if we can distribute it to the audience so they can take a look at that.
So just real quick, I've already sent it to you, and you can do whatever you want with it.
Well, look at you, Dan. You're just so ahead of the game. Thank you so much. Okay, so we will get that distributed. So that was
great.
That was one question. So any final, before we have to wrap up, and this has just been so enlightening and really wonderful that you were able to share all this. And really, I have to say, just so impressed with all the work that you're doing at your organizations and your commitment to EBPs, and I just feel very, very proud to know you, all of you. So any final sort of words of advice that you would give for those who are struggling? Yeah.
I just, one soapbox that I have is I'm here in Seattle. We're by the U. I hire a lot of social workers. Some people would say I'm a little biased. And I hire a lot of social justice oriented therapists whom I love. But one reframe I do on EBPs is the easy social justice question to ask is, who's included or not included in the research? But I think the harder question to ask is, don't, all communities have a right to access treatment that's proven to work? And so it's a direction to kind of come at some of my social justice oriented therapists and say this is about having equal access to treatment that works for all people regardless of socioeconomic status. So sometimes that's the way I get a buy-in that I wouldn't otherwise. But I tend to have a lot of social workers, so maybe that's more my shop than other people's.
So Georgiana, I just want to echo what Rachel just said. I think that's huge. When somebody comes and asks me, because I get lots of questions, I have this problem, what do you recommend? I can give you an EBP. I don't have to give you a therapist name. I can give you an EBP and then use the Harborview's the CBT Plus notebook where it has that series of questions that you can interview a therapist on. Have you been trained in doing A, B, C, D, E, or whatever it is? Have you had consultation in that model? In the past, you would say, hey, go see Fred. He's a good therapist. Now you can say, Fred knows TF-CBT, and that's the perfect thing for your child recovering from trauma. It's specific. That's what I love about this.
Great.
I'd like to add one thing, kind of a personal note. I had been a therapist for quite some time, and I was kind of struggling to figure out what I was doing, even with good supervision. But then I went to a training with essentially one of the founders of CBT, Donald Meckenbaum, in the late 90s. And it was really life-changing for me. And if someone's struggling to figure out what the meaning of this, I would recommend that they find somebody to see or read who really can sell it, because I left that 2-day training with the concept of what a good therapist was, and I thought I was a good therapist going into it.
Great. Well, we are. This could have been a longer webinar. I didn't see any other questions, so I just want to again thank the panelists, thank the audience for taking time and caring about this topic. If you have any questions, you can email Cassia Carey, who's here at our division. And if you'd like a certificate of completion for today's webinar, please be sure and complete the evaluation form that will follow this webinar, or you'll get an email follow-up that has the link to the evaluation. So if you complete it in the next week, we can get you that certificate of completion. And again, just thank you, panelists, for sharing your experiences and wisdom with all of us. There's really good nuggets, and what I'll maybe try to do is kind of encapsulate what were the main themes and send that out since we're out of time and not able to sort of do that. So thanks again, everybody, and we'll talk to everyone later.